So I wanted to also announce about that new Odell book that I have just recently shared in the group today. So the March candidates, obviously because they've read all these months the old Odell, so they should not be starting with the new Odell. But I think because now we've got extra cases and also some chapters have been updated. So for the September candidates, because you've only recently started, it's been only a week that the course has been officially started. So my recommendation would be to read from the newer Odell. And in fact, I would from the next cases also in the roster, I shall have to look and I might also start taking the cases from the newer Odell in the class. So that would be my recommendation because we have an updated edition and there are newer chapters which also include newer topics. So anyways, those topics are also important from the exam point of view. So I shall continue reading the newer Odell also. I'll take another day or so and I'll give you more insights on that. But for September, I would recommend that if you haven't started much in depth of Odell, then I would recommend doing the newer ones. Even in the March batch, if somebody wants to do the new Odell, then it would be advisable because you have an updated version, you have an updated edition, then there's no denying that you should be reading that. And about setting the paper from the old one, so it is always added information. On Odell, TG is the one which has more fact-like information and much more like a guideline. Odell is not a guideline, it's more like a clinical discussion. So newer the edition, better the discussion, more the topics discussed, better for your preparation in the exam. So from preparation point of view, I would advise that those who can read newer Odell should start doing the newer Odell because I would be also starting taking chapters from newer Odell from the next class. And also there are about 9 new chapters in new Odell. So I will also see if any of those are extremely important, then I would also incorporate them in the classes. And if those topics are somehow which you can manage by yourself, then you would continue doing them on your own. But if they are extremely important, like I feel that definitely there is going to be something in the exam from them, then I would try to accommodate that in our class. And also because we know most likely that exam might get delayed, so we can maybe stretch out our roster also a bit, but that would only be this time. From the next year, obviously, the time for preparation would be restricted and limited, so I'll also have to accommodate in the given 22 to 23 week time frame. This time, we can take that liberty and do those extra classes. But my honest advice is those who can, please do the newer edition. At least for the March guys, you don't want to read the entire Odell, new Odell, but do those last 9 chapters that they have added, the new chapters, please do those at least. In the classes from now, I'll be taking the newer Odell cases. Yeah. So today we'll be doing from the old edition, and from the next class onwards, we'll switch to the newer edition. Yeah. So let's continue where we left off with the 1000 file, which was question number 480. So a patient with reasonable oral hygiene has a small proximal caries on the premolar. So there's a small proximal caries on the premolar. The patient requests an aesthetic filling. Your preparation will be extending to what level? So if you have a proximal caries only on a premolar, then instead of going all the way and extending for extension for prevention principle is applied for your amalgam and not for the composite restorations. So if you're doing composite restoration, the bonding of the composite would be achieved with the etching and bonding agent on the small cavity box only. So we would still do the PRR, preventive resin restoration. That would be minimally invasive preparation of the caries, and thus only proximal caries removal in the proximal surface, on the proximal surface with occlusal and gingival bevels. Bevels will give you slightly more surface area and thus would aid in more retention. So extension for prevention and complete extension into the occlusal cavity for the retention is obviously not required with your composite restoration, which would be required for your amalgams. So if it's only you're doing it with your aesthetic filling, that's your composites. So you do not require the same amalgam preparation principles. You can just do with your proximal caries removal, minimal preparation, and thus only giving bevels for added retention. Which of the following is the most significant factor regarding the filler in composite for increased strength? So in the last class also, I talked about the filler component and the resin component. If you remember, we talked about how the physical properties are different and how they both contribute in a different manner to your composites. Like filler gives you physical properties and your resins give you aesthetic properties because they're more malleable, they're more plastic, they're more pliable, and which can be easily adapted. And then they also set with curing, and they also provide that translucency or the aesthetic effect to your natural tooth shade. But here it is asked regarding the fillers, that what is the most significant factor in regards to fillers only in composites for increased strength. So we know that fillers incorporate the physical properties which include strength. But what part of the filler contributes more? Is it the size, the volume, weight? What is that? So in each hybrid, microfilled, macro, small particle, there are difference in the weight or volume, and there's difference in the size as well. So size also contribute because larger the filler, it would have much more higher strength. But larger particles have one drawback. Larger particles of filler, when the composite is polished or is finished, the entire particle will be removed when it is embedded in your composite. So when you are polishing from the top surface, if a larger filler particle is removed, the void that is left behind is also larger. So your superficial surface would not have smoothness, but it would leave larger voids behind it. Whereas if you have a smaller particle, the size of the particle was smaller. First, you can incorporate many of the small particles compared to the large ones. So your small particles could be more voluminous, can be more in concentration per unit area as compared to your large particles. And also with polishing, the voids that the small particles leave behind are smaller, which are easily blended microscopically on the surface of the resin. So basically, they're more polishable. The small particles, they add to the translucency, they add to the smoothness of the finish. And plus also because they're more in number per unit area, so higher concentration of the filler particles gives much more strength as compared to the less volume per unit area. So it's more in the size, it's the concentration of the filler particles per unit area that contributes to the strength. We need much more concentrated filler particles than larger particles because they are going to be giving you the end result also non-aesthetic and also not much strength in terms of per unit area how much filler is going to be. So that's why nano-filled, nano-hybrid, they are most preferred when you're looking for posterior composite solutions because they come with small particles, nanoparticle size, and also comes with high volume or the high concentration of fillers in that particular unit area of the composite. So that's how it's going to give you higher strength as well as also surface finish or the surface smoothness is also going to be superior. A patient who has a small incisal fracture on the maxillary incisor, what would be the best material to resist the fracture at the acid-etched tooth composite interface? So if you're trying to restore it with composite, this was a fractured fragment and it has incorporated a little bit of incisal edge also, so it's an incisal fracture. And you're going to restore it with your composite build-up. So what kind of material would you prefer? So like we discussed, microfill has more resin, less filler. It would give you much more translucency, much more layering and much more absorption and the optical properties similar to your natural enamel. And hybrid, because it contains more fillers, it would not be as translucent. It would be much slightly opaquer than your microfill. and it would also have superior physical properties because of higher concentration of fillers. So because we are dealing with a fracture which involves incisal fracture, and we are not just doing a complete labial surface veneering with composite. So both of the demands or both of the procedures have different demands from your material. One is, suppose you were doing a labial veneer. It was a labial veneer with a composite, right? So entire structure of the tooth is intact. On that, for aesthetics, you're giving a veneer. So the strength part the tooth has. Aesthetics you want to give. So when you want to do a laminate with composite and you want to give that translucency or the enamel layers, which one would you prefer, hybrid or microfill? So when it comes to aesthetics, we'll go with microfill. But here, because you have a fractured component and you're building it up, and because in this part where there is no tooth structure, you're also building the inner dentinal layers with your composites. And that structure, which needs to incorporate the incisal surface, incisal edge, and also this much part of the bulk of the tooth, requires strength more than it requires your aesthetics. Yes, the topmost layers can be used. Definitely, whenever you are building up a composite, you're not always dealing with just one composite. You're not always using, you can't build up entirely in microfill, you can't build up entirely in hybrid. You definitely always require layering when you're dealing with composites, because each composite and each filler quantity imparts different properties. I mean, something gives you more strength, but inferior aesthetics. And the topmost layers, so you want enamel, and then you use your microfill, which gives you best translucency, but it would not be the best to give you the strength. So because you have a fracture, your main concern would be to build up, would be for strength. And in that case, the predominant composite that you would use to form the base would be hybrid. Only the top layer can be given with your microfill composite for your aesthetics. But if it was only about a laminate to restore the enamel layer or give aesthetics, then microfill is of choice. So here, because you need strength more than you would need the translucency, that's why hybrid composite is your answer. Now, while doing an RCT, you gave a dressing with a paper point, which was wetted with a certain intracanal medicament solution. So the patient arrives the next day with severe pain, right? So there was this RCT treated tooth, it was an infected canal, you wetted your paper point with a certain intracanal medicament and you inserted it into the canal and sent the patient home. Next day, the patient is showing you signs of inflammation. There is severe pain associated. It could have been an inflammatory reaction to that agent that you gave. It could have been some debridement, incomplete debridement, some necrotic substance left behind. But we cannot be sure of that, but we gave this paper point wetted with a particular solution, and the next day patient arrives with the pain. There is no swelling, but tooth is tender to percussion. That means there is a periapical reaction. So periapical reaction immediately the next day is most likely due to percolation of that intracanal medicament that you put there, which also brought about a reaction in periapical area, leading to tenderness on percussion, because percussion is a sign that the periapical area is irritated. So how would you do, or what would you do to manage this situation? So you are not going to replace with a similar dressing, considering there's a high chance that this reaction is coming out of that medicament that you put there with your paper point. And replacing or prescribing antibiotic also is not an ideal situation, because even if it's your remnant of some noxious necrotic pulp, then also you require it to be completely debrided. So ideally, you should take out this paper point, debride the canal, irrigate it, even if there is some necrotic elements left behind, that also gets eliminated, and then you replace that dressing with a corticosteroid base, because there's an inflammatory reaction now. So use paper point or any other lanceolospiral to inject or to put the corticosteroid intracanal medicament into the canal and also slightly into the periapical area to subside that inflammatory reaction that has been set up by this agent. There is no need to retrieve the paper point surgically. There is no surgical requirement. Paper point can become easily tweezed out. There is no surgical intervention required. Then removing the dressing and leaving for several days before replacing it. If you remove the dressing, but the periapical inflammation may not subside, it is acute, and the patient would want immediate relief, so then giving some anti-inflammatory agent would be a better choice than just leaving it as is, especially for several days before replacing it. And IND is also not required. INDs are mostly done when you have pre-op. Before you start your RCT, then you have a pre-op swelling. In most of the cases, then IND would be required. On the Friday class, when we continue and do more of these endo MCQs, I'm going to read from Walton on that day, Friday. So Diana, if you're here, you can remind me that as well. On Friday's class, I'll take brief 10 to 15 minutes and we'll discuss the endodontic emergencies as we spoke about also in the previous class. So it would be your pain situations, swellings, and flare-ups before you start your RCT, inter-appointment, and after completion of your RCT. We'll take that topic from Walton on Friday class. So I'll also tell you more in detail in what situations INDs are indicated and in what situations INDs not be performed. It's an inter-appointment flare-up. For you to understand, this is an emergency. Patient has come back next day with pain, but this is not before you started. This is not after completion of complete RCT. This is inter-appointment flare-up. Inter-appointment flare-up can be because of some noxious substances left behind or because of some medicaments that you have inserted, any reaction to that. There is no swelling in response to it. Even if there was a swelling, it would mostly be because of a necrotic leftover. So the ideal management is debride the canal, irrigate it well so that whatever irritants are there, they are flushed out, and then you just give an intracanal dressing or just give a closed dressing and maybe just ask the patient to take a stronger analgesic. That's all. Antibiotics are not required in this situation in inter-appointment flare-ups. We do not require them. So we'll deal about it. We'll talk about how to deal with such emergencies more on the Friday class. The best method of cleaning and toileting a cavity is ideally when you prepare a cavity for restoration, for direct restorations, the best way to clean them is with water. Alcohol is a desiccant. Citric acid was advised, or sometimes is advised to root condition when you're doing your scaling and root planing and then you want the reattachment. It was believed that it favors the formation of the newer cementum and your newer periodontal ligament fibers, but as per Carenza, it has not found to be true. So studies have indicated that both the treated teeth which were treated with citric acid and not, after successful completion of scaling and root planing, subgingival root planing, they responded equally. So citric acid treated roots or citric acid conditioned roots did not give you any better periodontal attachment than non-treated ones. So it is not used for cavities, but sometimes earlier was used for your root treatment. Again, an organic acid is also not required. It's only a water that you should clean your cavities with. One more thing that you may use only, but when you're using your GIC as your restoration, is you can condition your dentine by using your polyacrylic acid. But that is not for cleaning and toilet of cavity. That is the dentine conditioning. It is conditioning of your dentine, opening them, widening them, so that your chemical penetrability of GIC is improved. So only with GIC you treat your dentine with polyacrylic acid. Otherwise, when you're doing amalgam or composites, the cleaning of the cavity for the leftover tooth structure debris that was removed is only through your water. And you should not dry off your cavity through your air blast, but rather only use your cotton pallets to lightly pat it dry and swab with your cotton pallets. Not use your air blast because that leads to retraction of odontoblast into the dentinal tubules, which can be even permanent. Then periapical abscess is differentiated from periodontal abscess. So we know a periapical abscess is coming from a non-vital canal and a periodontal abscess is coming from a deep periodontal pocket which got obliterated on top by plaque and calculus, and underneath the bacterial products, the bacteria, which continue to degrade and degranulate the periodontal tissues. The pus is released, and this pus initially was having a vent, but because the pocket top got obstructed and obliterated by the plaque and calculus, now it has become, the pus is getting accumulated and it has become a swelling. So this is also a swelling, but it is because of periodontal pocket, which got obliterated, and now the pus is accumulated. So it is associated with your periodontitis, but not with a non-vital pulp. If it's not a very deep pocket and there is no accessory canal here, that this infection can reach the pulp through those accessory canals, then this is your true periodontal abscess. There is no pulpal involvement. Whereas the one coming from a non-vital pulp, in the periapical area, because of the destruction of the minor dura and the bone, now the pus is accumulated here, but it can tend to spread on the facial surface and can again give you a swelling on the labial sulcus. So both can be seen clinically as labial sulcus swelling. It can be a swelling on the labial gingiva. Then history is still not important, but vitality test would definitely be different for the bone, because the periapical abscess is definitely coming from a non-vital pulp, and a periodontal abscess in its true sense, yes, it can later involve endodontics. It can involve pulp with infection through your lateral canals. That would be but your perioendolesion. It would not be a true periodontal abscess. So a true periodontal abscess is only accumulation of pus in your periodontal pocket, and thus comes from your truly vital pulp. There is no response, there is no contribution of the infection or non-vital pulp into that abscess. Upon X-ray also, this can appear similar, because your endodontic abscess can also disrupt your bone labially. So it can give you this radiolucency present on the lateral surface of the wall instead of completely being in periapical area. So it can give you a lateral spread. It can look like a deeper periodontal pocket. So even a periodontal pocket can extend periapically. So these can have similar radiographic appearance. These can have similar clinical appearance in terms of pain. When you press the gingiva, or when you press the labial attached gingiva where the swelling is present, it could give you the similar clinical features. It would be similar swelling on the labial attached gingiva. Radiographically can also be similar. Pain can also be similar. But what would be different, especially in initial stages, when there is no lateral or retrograde pulpal involvement through periodontal lesion, till that time, the periodontal abscess tooth is going to have and give you vitality response. Whereas the periapical abscess will not give you vitality response because it's coming from a necrosed pulp. So vitality test is always the best answer, or the best solution, or best way to differentiate a true periapical abscess from a true periodontal abscess. A patient suffers a blow to their maxillary central incisor, but there was no fracture. So if there is no fracture and there was a blow to a tooth, so it's a concussion, there was no subluxation, there was no luxation, there was no movement displacement. So if there's concussion, it was a severe blow, no fracture, then most likely the tooth becomes non-vital. It would not be immediate necrosis. The pulp would start showing the reaction slowly, but it would become non-vital irrespective of the treatment. It will only become non-vital if treatment was delayed. There is no treatment per se for this tooth. Prophylactically, you would not start RCT unless you get signs of your necrosis. So that's why there is no treatment for the same, because it has not been mobile. It is only concussion. There is no luxation, there is no subluxation, there is no mobility, there is no displacement, there is no fracture associated with the alveolar socket wall. So no treatment required. So this treatment doesn't make sense that it will become non-vital only if you delay the treatment. There was no treatment required at that point. We have to just wait it, and eventually, because pulp took all the brunt of the trauma, it will go under necrosis, most likely. No changes seen if fracture does not occur, that happens rarely. So mostly pulp taken the brunt would become non-vital irrespective of the treatment. The pulpal floor of the class 2 cavity for a mandibular first premolar. This was the first question when we started this file. The buccal and the pulpal horn heights are different. So whenever you're creating a cavity, mandibular, the floor has to be lingually tilted. It is not parallel to your occlusal plane. You may think that this is your occlusal plane, but this is not occlusal plane. This is occlusal surface of this tooth. There is a difference in occlusal plane and there is a difference in occlusal surface. Each tooth has its occlusal surface. Occlusal plane is what is between maxilla and mandible, all the teeth. That's a constant plane. Not all teeth occlusal surface is parallel to the occlusal plane between maxilla and mandible. So maxilla versus mandible is the occlusal plane. Each tooth has an occlusal surface. So the occlusal plane passes through the cusp tips on the premolar would be like this, but the occlusal surface is lingually tilted. So occlusal surface is not parallel to the occlusal plane of the mouth, and that's why our floor is parallel to the occlusal surface, but not parallel to the occlusal plane. So that's why A is not correct. And it's also not perpendicular to the long axis of the tooth. So that's why B is also incorrect. It is tilted lingually. Marginal leakage seen at the proximal surface, gingival cable surface of a recently restored class 2 can be caused by. So let's imagine what it means to ask here. Right? If this is the tooth that you're restoring, it's a class 2 cavity. So this is the occlusal component. And this is your proximal box. So micro leakage at the proximal gingival cable surface. Proximal gingival cable surface is this. This is your proximal wall. This is gingival seat. So this marginal leakage at this point where you put your restoration can be because of. So let's look at it. Let's try to imagine in what situations we can have discrepancies and gaps at the margin here when you're putting a proximal restoration. If you did not condense your amalgam sufficiently, absolutely correct. Whatever the material, your composite or amalgam, if you're not condensing it well, adapting it to the surface, you may be leaving gaps in these surfaces. Absolutely makes sense. First proximal increment was too large. When you put a large material together and then you try to condense it, the chances of creating voids is higher compared to when you put smaller increments, which are more easily adapted, or rather well adapted with your condensation. So the increments should be smaller and not too large. They can also lead to voids and thus give you marginal leakage. Neglecting to wedge the matrix band. So because for your proximal cavity, you would have placed a matrix band here, which would try to give you the recontour of the proximal wall, and to make sure that condensing forces are not pushing the material out from this margin, you have to wedge it also. So wedging is done to adapt the matrix band to the tooth structure and also try to create separation between the adjacent teeth so that your thickness of your matrix band is also compensated for. If you do not put this wedge here, and even if you used your normal forces, there could be slight extrusion because there was no force here which was trying to closely adapt it. So condensing forces would extrude your material out. You will get an overhang here. And plus, when you take out that matrix strip or matrix band, because the separation was not achieved, teeth will not go back together and will not achieve a close contact with adjacent teeth. So this thickness of the matrix band would be left behind as a gap. So matrix band thickness is compensated for by this separation of the teeth achieved by wedging. It separates the teeth. Once you take out the wedge, filling is done, you take out the matrix band, then that separation is also dissolved and the teeth come together. And then the thickness of the proximal band or the matrix band is compensated for. So you're not left behind that thin gap of microns, which can lead to further food impaction, lead to your periodontal destruction. So when you neglect to wedge the matrix, you either get periodontal problems because you're left with gaps, or here at the proximal cavus surface between gingival seat and the proximal wall, there would be an overhang. There would be an overhang. You will have restoration extruded out. So that would not be gap, but it is an overhang which can retain plaque and give you periodontal destruction. But it would usually not give you marginal leakage because it is an excessive material, not deficiency of it. Micro leakage is seen associated with deficiencies or gaps, not with excess overhangs. So neglecting to wedge the matrix is wrong. It will give you gap on the marginal ridge surface, will give you overhangs, but it did not give you marginal leakage. So 3 is not correct. Then hand manipulation instead of mechanical. As per your Sturtevant, hand manipulation is superior to mechanical, so it should always help in closer adaptation, not lead to marginal leakage. So hand manipulation is superior than mechanical, so 4 doesn't make sense. And also Dinah, if you're putting the list for today, please share the first reference, Sturtevant reference, that hand manipulation should be done and mechanical is not preferred or should be avoided. Even so, I saw this question on this chat. No, saline is not used for your cavity cleaning. I'm not saying saline to use your cavities when you're preparing them. Saline is used in your live tissues, which is your enamel and dentin, so you're not using saline. It is not the soft tissue. So in your peripical surgeries, yes, you can use saline to clean that area, but not cleaning your cavities or restorations or the cavity preparations. No, even when given as saline, water is the one that you use. So debris contamination, if you were adapting it and there was debris contamination in the proximal surface, between the proximal surface and between the restoration, so because when you adapt it closely, the debris would still be accumulated there. After removal, when the patient is gone off with your oral hygiene, with your chewing, all the forces acting, the debris would be removed. And when debris is removed, it leaves gaps and voids again between the tooth and the restoration. So again, that can also lead to gaps and lead to micro leakage. So 1, 2, and 5 would lead to micro leakage and gaps. 3 will give you overhangs. 4, in fact, is a superior method to avoid marginal leakage, right? So 1, 2, and 5 is correct here. And that would be all for today that we discuss this file. And Wednesday class also, I'll do more pages, 18 and 19. Yeah. All right. So that would be it for the MCQs in today's class. And let's go to Odell now. So Dinah, please remind me, I have to share this added notes file on the group after the class. The Salt Endo file with more notes. And let's start the case of gingival recession today. Yeah, Aline, I'm reading out your question here. Aline has a question. How about if you don't put the wedge in a good place and overhang is there? When you take out the matrix and it breaks, it will be void as well. Well, if that happens, Aline, then in most of the cases, the entire proximal restoration may also come out of it. So we are still, that is why that is also one of the possibility, but that would not be a micro leakage case. That's like a complete fracturing of the restoration. So we are talking about the situations here which actually give you just enough gaps to not fail the restoration. It would not be a fracture of restoration, but yet give you the gaps which can lead to micro leakage and development of secondary caries, right? So if it breaks, it would actually be breaking the major chunk and you would be repeating that restoration. You would not leave it off as a micro leakage, right? So that is very difficult to be missed out. Those debris contamination and the voids because of your large increments are easily missed out. And from the top, you might think that it's the best looking restoration in the world, but it would be coming with your gaps and discrepancies. So if you're taking the matrix man and usually it breaks out the restoration, that can be easily appreciated. And usually the whole proximal box comes out of it, so you would be repeating that restoration. Yeah, so hope that answers your doubts. So let's move to the Odell case discussion. Now with the perio classes also, what there is this thing that when I start teaching you perio, so even when we go to the 1000 MCQs today, we are starting with the gingival lesson, and it is going to be the first perio lesson actually. So there are various grafting techniques, and then there are various treatment modalities, surgical treatment modalities in perio. So if you really wanted to do it as a one class, then we can actually totally dedicate entire one class to it. So that's why I can't be teaching you 2 Odell cases and all the perio surgical modalities together. That's why what we do is, instead of doing all the cases together or all the surgical methods together, we do it as it comes as a question. So we start with the session. In this one, because they have done a free gingival graft, I will be teaching you in detail about a free gingival graft, a little bit on the connective tissue graft as well. But as we start the perio questions and more questions on the grafts keep coming up, then I'll explain each grafting technique with each question. And once we are done discussing all the grafting technique, then we'll have a quick session, maybe 10 minutes, 15 minutes to revise all those techniques. And I will rather also give you some articles where you can revise all those techniques together. Yeah. So for now, we'll only dedicate and do as and when we come to each technique that we're reading about. So let's start with gingival recession and its management. So it's about a 30-year-old woman who has gingival recession, assess her condition, and then discuss her treatment options with her. So this is a clinical presentation of this patient. As you can see, the gingival margin, let's just draw it out so it is highlighted and you see the various difference in levels of the gingival margin. So that's your margin, the top of the margin. That's where you also see the free gingival groove. And then this is your attached gingiva, alveolar mucosa, where there's hardly any alveolar attached gingiva. So the pink part is your attached gingiva, the red part is alveolar mucosa. So with your marginal gingiva and alveolar mucosa, in certain teeth, there is sufficient attached gingiva, but in certain teeth, exactly after your marginal gingiva, you have alveolar mucosa. You have no attached gingiva at certain situations. So in ideal health, you must have free marginal gingiva, which is your crest of the gingival sulcus, and then your depth of the sulcus, which is externally presented as your free gingival groove. Below that is your attached part of gingiva, which is connected to the root and also the crown and also to the bone. So that attaches itself with your gingival connective tissue fibers, and then below that is your pedial fibers, and below that is your loosely lying alveolar mucosa. So attached gingiva is an important aspect of gingival anatomy. When you look at it from the side view, that's your CJ. This is your interdental bone, the crest of the bone. Now, usually CJ is where your sulcus depth should be located. That's your gingival margin. This is your external representation of gingival sulcus, which is your free gingival groove. Now, from your gingival sulcus to the crest of the bone is your attached gingiva. So it is comprised of your gingival connective tissue fibers, and below that is your pedial fibers. So this external thickness is your attached gingiva. This is your PDL below this. And this is also where your alveolar mucosa starts. So just below the crest of the bone is where your alveolar mucosa starts. So whatever lines the bone is alveolar mucosa. On the top of it, whatever is attached to the root is attached gingiva. And just above your junctional epithelium, the remaining gingiva is your free marginal gingiva. So first of all, I hope everyone is familiar with the anatomy. The free marginal gingiva, that's your sulcus. It increases in depth in your disease and periodontitis. Then below that is your junctional epithelium and gingival connective tissue fibers, which is your attached gingiva. Then is your periodontal ligament, and on the external representation you have alveolar mucosa lying there. So alveolar mucosa is loosely bound and not attached to it, whereas attached gingiva has insertions of connective tissue fibers on the root surface. So now this attached gingiva imparts health and resists the forces on the gingiva, makes sure that the gingiva is closely adapted. When this attached gingiva is missing, suppose below your gingiva, below your free gingiva, immediately is there your crest of the bone and alveolar mucosa. Like in this situation, there's only a marginal gingiva, no pink gingiva, that means no insertions on the root, and that's your remaining bone level, and you have only alveolar mucosa. So alveolar mucosa being loosely bound on the root or on the bone would not be able to take the masticatory forces and recedes at a faster rate than does your attached gingiva. Attached gingiva, because of its connective tissue fibers, resists the forces better and resists your recession better. So that's your anatomy, understanding the aspect of alveolar mucosa and attached gingiva. Let's look at the clinical case here. So patient is worried about their gingival recession around her lower front teeth, which she feels is worsening. That means it's increasing than what it was before. So she remembers noticing the recession for at least the previous 5 years, and she thinks it has worsened over the last 12 months. There has recently been some sensitivity to hot and cold and gingival soreness, most noticeably on toothbrushing or eating ice cream. So gingival soreness, that means mild pain in gingiva, and hot and cold sensitivity on the same area. Now hot and cold sensitivity is linked with two important clinical conditions. One is your pulpal condition, pulpitis, and the other important is, where there is no pulpal involvement, is your dentinal hypersensitivity. So dentinal hypersensitivity is the other clinical condition which is linked with hot and cold sensitivity when there's no caries, no pulpal involved. So most likely in this patient, because there's no caries on the tooth surface, it is your dentinal hypersensitivity which is closely linked with your recession. As the recession takes place, you know when the recession would have taken place, so gingiva is receding down, so root surface starts getting exposed. So that means there is minimal free marginal gingiva and then alveolar mucosa, hardly any attached gingiva, and the root surface is exposed. So bone levels are also receding, the bone is also receding, and the sulcus depth is also receding. That's the concept of biologic weight, by the way. Let's also discuss biologic weight today in today's class. So as I drew this for you, the basic anatomy, right? This is your sulcus in health. That's the base of your sulcus. Just below the base of the sulcus, you have your junctional epithelium. The most average length of junctional epithelium is 0.9 millimeters, say about 1 millimeters. And then below that, you have your gingival connective tissue fibers. The total weight of junctional epithelium plus gingival connective tissue fibers is somewhat 2 millimeters. And this total weight, which includes JE plus gingival connective tissue fibers, is 2 millimeters. And this inclusive weight is called as biologic weight. So this total tissue above the crest of the bone, which is your junctional epithelium and connective tissue fibers, is called biologic weight. Below that, once the bone starts, then the periodontal ligament starts, right? So now this is your free marginal gingiva, and this is biologic weight is comprised in your attached gingiva. Below that, you would have mucogingival junction, so your alveolar mucosa begins. So I hope the anatomy so far is making sense for everyone. Please type down yes if it is, yes. So this is the anatomy: free marginal gingiva, attached gingiva, and then alveolar mucosa. This is in normal health. Now biologic weight, please remember, always remains constant. Always remains constant. Why? Because of disease, when there is periodontitis or recession, whenever there happens with the recession of the sulcus, when the gingiva starts to recede, the sulcus will start to recede, JE will also recede, connective tissue fibers will also recede. So to maintain this 2 millimeters of thickness, the bone will also start resorbing. So bone starts resorbing so that if the sulcus recedes down, if the sulcus comes here, to maintain this biologic weight, bone levels will also go down. So that's the beauty of it. Biologic weight always remains constant. If you give a prosthetic crown, which invades, and which is subgingival, which invades the health and the flora of your sulcus, it can lead to periodontal destruction. Specifically, it is not giving you periodontitis. It is just leading to destruction of these fibers by impinging them. So if it's impinging the biologic weight, the fibers are broken down. So sulcus would be deepened. Sulcus deepens. When the sulcus deepens, then bone levels will also go down because this biologic weight will always remain 2 millimeters. So because biologic weight always remains constant, the sulcus goes down, the bone level automatically goes down. Same principle applies in periodontitis. Same principle applies in your biologic weight violation with your prosthetic crowns. Same principle applies in your gingival recession. Periodontology destruction, however it is, from prosto, from periodontal disease, or from your recession by mechanical trauma. By whatever means there is periodontal destruction, the concept is same. You can expect to see the same anatomy. Sulcus will recede down, the fibers, the JE will recede down, biologic weight will be constant, and your bone levels will be down, right? But there can be certain cases where there is this entire attached gingiva can be missing. That can be because in severe destruction, this recession, this bone destruction is not catching up with this attached gingiva destruction. Like in this patient, she comes with only marginal gingiva and then there is alveolar mucosa. There is no attached gingiva. That's because recession is so rapidly happening here in this particular case that now all the attached fibers have been destructed for her. There is no attached gingiva, but the bone destruction is still not catching up. So it is so severe that ultimately it would catch up. Ultimately, the bone would recede to maintain the biologic weight, and the fiber destruction will also continue to happen. So that's why you can lose out such teeth immediately. The prognosis is severely poor if you're not, and if this recession or destruction is not managed immediately. So we need to manage for this patient because the destruction now is happening rapidly for her. So now let's look at this. So I hope everybody understood the concept of biologic weight as well. Now she notices some sensitivity on toothbrushing or eating ice cream. Upon dental history, the patient has been a patient of your practice for about 10 years, and you have discussed her recession at previous visits and then reassured her as well. She has low caries rate. She has generally good oral hygiene. she's fit and healthy individual, is not a smoker. Now, what specific questions would you ask to help identifying a possible cause? How often do you brush your teeth? First question that you will ask them, because toothbrush trauma is also commonly linked with localized recession. Provided toothbrushing is effective, cleaning once a day is sufficient to maintain gingival health. However, most patients clean 2 to 3 times each day, and some brush excessively in terms of frequency, duration, and even the force that is applied. So trauma from toothbrushing is considered a factor in some patients' recession, and recession may indicate a need to reduce the frequency and also the duration of cleaning while still maintaining its effectiveness. So it should be able to remove the plaque, but should not be that aggressive that it is destroying your gingival fibers and gingival tissue at a rapid stage. So in this instance, the patient has a normal toothbrushing habit, but should clean no more than twice each day for a sensible period of time. Has she also ever had an orthodontic treatment? Because the lower incisor is missing here. You see 9s here, and only 3 incisors. So 3 incisors, 1 incisor is missing, suggesting that some intervention may have taken place. Fixed ortho in the lower labial segment is also associated with gingival recession in patients who have thin buccal gingiva, narrow alveolar processes, and correction of severe crowding. So thin buccal gingiva, what does that mean? Thin buccal gingiva means that gingiva has its topography. So gingiva has its own thickness or thinness, and in certain areas the gingiva can be few cells thick or less in thickness, and which is more friable and more prone to recession compared to the areas where the gingival topography is thicker. So thicker gingiva is less prone to recession, thinner gingivas are more prone to recession, and that's why they also sometimes succumb to the toothbrushing forces. So even in the orthodontic treatments, those thin topography gingiva is more prone to show you recessions. Plaque control may be compromised during the wearing of an orthodontic appliance, and even over a relatively short period, this can even contribute to a problem. So in this instance, patient had undergone extraction of incisor but did not wear an appliance, so ortho is also not most likely the contributory factor of this localized recession here. Then upon intraoral exam, the appearance of the incisors is seen. What do you see? So there is a missing lower left central incisor, there are unrestored teeth, there is no plaque which is visible except for a small amount at the cervical margin of the lower left lateral incisor. The gingival recession is affecting all your lower incisors and to a certain extent the lower canines as well. Apart from your abnormal contour, the buccal gingiva are pink and healthy, and the interdental papilla are normal. Then reduction in the width of keratinized or attached gingiva, in places even attached gingiva appears absent, especially like your left lateral incisor here, which is showing absolutely absent attached gingiva. Even with your right central and lateral, you have minimally present attached gingiva. Easily you see the beginning of alveolar mucosa. So there is also lack of attached gingiva, insufficient width there. But in certain places like this one, the left lateral incisor, it is absolutely completely missing. So what clinical assessments would you make, and how would you make them, and why are they important? So what are the clinical tests that you would perform for this patient, and why would you do each of them? And when you learn this table, you will assess in any condition of recession, in any periodontal SDQ that you get in the exam. These are your parameters that you need to assess to understand the status of periodontium in that area. All these testings are required when you're assessing the patient with recession or any other periodontal problem. So first, to check the recession. How much is the recession? Recession would be measured as you look at this diagram here. So recession, ideally the base of the sulcus should have been at CEJ. Recession means if the sulcus goes down. When the sulcus goes down, the free marginal gingiva also goes down. So the top of the marginal gingiva to your CEJ, that distance is the amount of recession. The exposed root surface from the top of the sulcus to the CEJ, that's your exposed root surface, and that's your value of gingival recession. So recession has to be estimated. You have to measure it from the gingival margin to the CEJ, and it gives you the baseline reading as to what is the level of your recession today, and if you assess the patient a few weeks later, how fast or is it progressing or not. So assessment of progression would be estimated on that. Then probing depth. Probing depth would give you the loss of attachment as well. If the probing depths are increasing, that means it's not receding. The margin may be at the top. It may not be exposing the roots, but the attachment loss is still happening. The sulcus is still going down. Free marginal gingiva, even if it remains at the top and CEJ is not disclosed, even if the root is not getting disclosed, sulcus goes down. If the sulcus is deepening, CEJ was here, sulcus goes down, marginal gingiva may remain where it was. So deepening sulcus means there is loss of attachment. Fibers are going down, bone is receding, that's why sulcus is deepening. But there is no atrophy of this gingival tissue. So basically it's not recession, but still there is loss of attachment. So that is still destruction of periodontium. And this is linked with periodontitis. So still you also have to assess for probing depths. It also detects the loss of attachment, undermining the reduced width of attached gingiva. Because when this goes down, previously all this was your attached gingiva attached to the root surface. Now it's becoming all free gingiva. So there is still reduction in the width of attached gingiva. Then you check for bleeding and probing, which gives you this sign on inflammation and poor hygiene. If the poor hygiene is good, if the inflammation is subsided, there would not be any bleeding on probing. Then amount of attached gingiva, how would you identify that what is the attached gingiva? So as you have this tooth here, and the sulcus goes down, this was the CEJ. So earlier here was your sulcus, and the same free marginal gingiva height. Now this has gone down to this level. So earlier, this was your attached gingiva. The bone levels were also here, maintaining the biologic width. Bone levels were here. Now the bone levels have also gone down. So earlier, this was your attached gingiva. Now this has all become your free gingiva now. With the loss, destruction of the bone, and your free marginal gingiva extending, base of the sulcus receding, this all has become free marginal gingiva. So width of your attached gingiva is also going down, because earlier all this was your attached gingiva to the level of your crest of the bone. Below that is your alveolar mucosa. So it also gives you amount of attached gingiva. You get the value of your attached gingiva by subtracting the probing depth. So whatever is the probing depth now, say it has your 6 millimeters probing depth, and minus the width of keratinized gingiva. So probing depth minus whatever is the keratinized gingiva, because non-keratinized would be your alveolar mucosa. So whatever is the remaining keratinized gingiva minus the probing depth is your remaining attached gingiva. So earlier, all of that was your attached gingiva. Now only this much remains as your attached gingiva. So the width of attached gingiva also reduces as your probing depth increases. Then presence of functional attached gingiva. So sometimes in certain areas, even 1 millimeter of attached gingiva is sufficient, and in certain areas, even 3 millimeters would not be sufficient. So how do you say that whether this gingiva is sufficient or not, or functional or not? Then you test it by placing tension on the attached gingiva or the gingival margin. So you pull the lip, depress the lip, or depress the labial sulcus mucosa, which will push the tension on your free marginal gingiva. So if your free marginal gingiva gets displaced, if your gingival margin gets displaced, if your sulcus gets displaced, then it means that it's putting pressure on your free marginal gingiva. That means your attached gingiva thickness is not sufficient to keep it in place, so that your forces or the lip pull will continue to pull it down and the further recession will continue. So tooth mobility then, because that will also give you much more prognostic factors and prognostic indications about what is the remaining amount of bone levels, whether this tooth can be saved in future or not. Vitality test will also be helping, because even if the prognosis seemed good, but if the tooth is non-vital, then other treatment modalities would be required that would deteriorate the prognosis. Non-vital teeth would be compromised, they would require pulp treatment, then they would require some kind of coverage or some kind of prosthesis or any restoration. So all that also be needed to be taken into account when you're planning the entire treatment. Some might require extraction, some might require saving. Then occlusion also needs to be assessed, because in certain situations, certain traumatic overbites can also cause or exacerbate recession. Now, this one is an important point, because if we have an exam in SBQ where there was a deep traumatic bite, which has led to localized recession for that patient. So deep traumatic bites, traumatic overbites, and also edge-to-edge occlusions can also be responsible for your localized recessions. So generalized trauma from occlusion or any trauma from occlusion will not give you generalized recession. How would you differentiate the recession as the cause of occlusion? Because if it's caused from a traumatic occlusion, it would only be localized. It would not be generalized. Then you can put to the list. I'll also share the reference and the case reports where there has been cases of localized gingival recessions because of your traumatic occlusion. So we have had an SBQ. We'll do that entire SBQ. But first of all, let's build the concepts. Let's build the concepts that yes, the traumatic occlusions, the deep bites, the edge-to-edge bites can lead to localized recessions, especially in your anterior incisor areas. So Diana, please put to the list so I can share the case report. Because if you have seen few case reports, then your mind would know that yes, this is clinically happening. So that if you're presented with a certain clinical situation in the exam, you would know that this is a possible etiology. So these are the areas or the parameters that you would assess. When you perform such assessments for this patient, you find that probing depths are normal. There is no deepening of the pocket, so there is no periodontitis per se. The probing depths are normal, 1 to 2 millimeters. There is attachment loss, but there is also atrophy of mucosa along with it. There is no deepening of sulcus. There is no increased probing depths. The mucosa is also atrophying with it. The width of keratinized gingiva varies with the degree of recession. The lower left lateral incisor has no attached gingiva. Tension on the lip displaces the margins. If the displacement of the margins is happening on these teeth, then that means that this is no functional attached gingiva. So this sign, lower left incisor has no attached gingiva at all. And when you're pulling the lip, it is also displacing the free marginal gingiva. That means there is no functional attached gingiva in this place. So whatever remaining 1 or 1.5 mm in the adjacent teeth also there, that's also non-functional. No teeth have increased mobility. No possible occlusion factors are there to cause or exacerbate this recession. There is no reason to suspect the loss of vitality, and all teeth respond to testing. So all this has made some sense with the assessment, and now let's put that all together and see what is required for this patient now. So what investigations would you perform? What radiographs would be indicated? Then radiographs would give little additional information in this case, because the bone loss that is happening with your gingival recession is also happening on the buccal aspect. So root is going to hide and superimpose on the radio opacity. So the bone loss would not be appreciated on the buccal aspect, because all that radio opacity would be from the roots. Radiographs might be helpful if the interdental bone loss was suspected, but looking at the genetic picture, the levels of the interdental papilla seem at your accurate levels. If you look at it, almost at just below your contacts, that's where they should be. So levels of interdental papilla absolutely seem correct. That means there is no loss of interdental bone. There's only loss of buccal bone, along with which the gingiva is also atrophic. So only radiographs would have been taken if you suspected any interdental bone loss. Now, together with minimal probing depths, they all suggest that there's normal interdental bone height. A radiograph would be value if mobility was indicated, and then you have to assess the amount of root length and bone height. So in this case, that's not present, neither is mobile, nor there's loss of interdental papilla, so radiographs would not be indicated. Now, what's your diagnosis and what is the likely etiology? The patient has gingival recession. That's for sure. We know that CJ is exposed, root surface is exposed, gingiva is receding, bone levels are going down, attached gingiva is insufficient in certain areas. The patient is dealing with gingival recession, and because it's less than the 30% of the site, it is your localized gingival recession. In this case, assessment has not provided a diagnosis any more accurate than that given by the patient, but the features should give some clues to the possible etiology. Recession is probably multifactorial in etiology. Most important factor is anatomical variation between the patients. Some individuals have thin gingival tissue, so the topography changes. You have to remember the thin gingival topography compared to the thicker ones is more prone to the recession. So when the buccal plate of alveolus is also thin, then bony dehiscence and fenestrations are more likely. Now, dehiscence and fenestrations. So if this is your tooth structure and this is your root and this is lined by your buccal plate of cortical bone, so a dehiscence would be a narrow cleft-like resorption of the bone, and a fenestration would be where the margin of the bone is intact, but there is bone loss like a window. So there is the marginal bone is still intact, but there is bone loss happening on the like a window. Dehiscence would be merging with the marginal bone. So fenestration can also convert to a dehiscence if this remaining marginal bone also gets destroyed. So if this remaining marginal bone also goes, then this also becomes a dehiscence. So dehiscence is a cleft-like bone loss where marginal bone is also gone. Fenestration is window-like where for a while the marginal bone can remain, but that also because being so much less in thickness and because there is inflammation and positive factors for destruction, so that amount of marginal bone also goes off in less amount of time. So that also ultimately becomes a dehiscence. So in such individuals where you have thinner gingival type, thinner alveolar topography, in those situations, your recession, your dehiscence, fenestrations, they're all more likely. For these reasons, there is more recession on the teeth which are prominent in the arch. So more buccally prominent teeth also, they are more likely to face localized recessions. When these predisposing factors are present, other insults like your normal tooth brushing or some finger tooth biting or some factitious forces with your digits, they all become more exaggerating to your recession. So the most important is probably toothbrush trauma, and then plaque-induced marginal inflammation will also be able to destroy the thinner tissue relatively quickly, and traumatic occlusion can also contribute. So even you know that all these are etiologies: plaque-induced recession, traumatic occlusion-related recession, or your toothbrush trauma-related recession. All these three factors would be far more contributory if the topography of the gingiva was thinner. In this case, patient is maintaining a good standard of plaque control. There is no cervical abrasion, so which also indicates that toothbrush is not the likely cause. Because if toothbrush was harsh, if the patient's toothbrushing was hard, then it would also be destructive to the tooth structure, giving you cervical abrasion notches. Cervical abrasion lesions would also be present. Because they are not present here, so that can be still a further evidence that toothbrush trauma is not the likely cause in this patient. So that's missing here. And what evidence and treatment would you provide? So you ensure a sensible, atraumatic, well-effective brushing regime. You would still put them and tell them for correct brushing regime, because we know that most likely in her case, it's the topography of gingiva, which is more prone for recession, but these forces will add on to that destruction. So she needs to be explained the importance of keeping it plaque-free, keeping the forces as mild as possible so that the destruction is not adding on, so that these are not the contributory factors. Then you reassure the patient that the condition is not necessarily progressive, although this is irreversible. It is highly unlikely that you can gain the height and width both of the bone and then put the graft there. You can maybe just give cosmetic coverage of the roots, but you cannot reverse the loss of bone. Some amount of width can still be achieved, but gaining the height of the bone back is usually irreversible. Monitor for progression with the aid of clinical measurements. You can use clinical drawings, photographs, or study casts, which will help you how it is progressing. And treat the dental hypersensitivity, because the chief complaint was also sensitivity to hot and cold. Recession is not painful, but because it leaves behind exposed root surface, and because of their caries or erosion there, you can obtain loss of cementum, and thus dental tubules would be exposed. That would give you sensitivity. So make sure that there are no sugars in the diet, so that the caries do not take place on the root surface. Acidic drinks and foods are also not taken, so that erosion of cementum do not take place. And then, because she already has sensitivity, so you know for her dental tubules are exposed, you need to apply your topical anti-hypersensitivity agents as well. So this is another reason to perfect the cleaning of these teeth, because we will come to certain questions where we'll be dealing about the hypersensitivity, and I'll read an excerpt from Carenza for you all. And we'll read an important point in that hypersensitivity from Carenza, which is the foremost important point in management of dentine hypersensitivity is keeping the area plaque-free. First and foremost, your anti-hypersensitivity agents, your fluorides, your restorations, everything follows. The most important aspect of maintaining or treating hypersensitivity is keeping the area plaque-free. Now, in this case, the patient maintained good plaque control, but the recession has worsened slowly over a period of several years until there was a lack of functional attached gingiva. What other treatments might be possible, and are they effective? So let's talk about the treatment possibilities and what was performed for this patient. And here I will explain the free gingival graft. So the treatments are, because the problem is gingival recession, one is to do a mucogingival surgery to correct the recession. That is a coverage. When you talk about mucogingival surgeries to correct the recession, that means you're correcting the exposed root surface. So when you're correcting the recession, you're trying to provide coverage to the root surface. You're providing coverage. So let's talk about this. Let's look at this image. This is the CJ, this is the exposed part because of recession. If you want to correct this recession, you are providing coverage. So coverage can be given by these grafting techniques: lateral pedicle, double papilla, or a coronally repositioned flap, which can be used in conjunction. As an additional, you can put a subepithelial connective tissue graft with these methods. So these are three grafting techniques: lateral pedicle, double papilla, and a coronally positioned flap. Briefly, I'll introduce you to them today, and when we start the 1,000 questions, I will go in depth. Briefly, I'll just take them. So if you're doing a coverage, let's look at this one. This is dealing with, again, the recession. This is actually the example of fenestration where the marginal gingiva soft tissue is intact. This is a bone loss and tissue loss in a manner of like a window. And this will also be destructed soon. And then this will become a complete recessed area, exposing that amount of root. So if you were to treat this recession by a coverage procedure, if you were desiring a coverage procedure, double papilla means you are taking the graft from two papillas on the adjacent side. You will give the vertical release and horizontal sulcular incisions in these areas. Double papilla, you're using your two papillas, right? This side and this side. So you're taking complete papillas. And it would be your partial thickness flap. You will not be raising it entirely from the bone. You will split it and leave behind certain periosteum lined over on the bone, so that also gets reepithelialized. Some connective tissue would be left. So that would be a partial thickness. You will not denude the bone because you have to keep certain tissue for this donor side also. So you'll remove a partial thickness flap from here, partial thickness flap from here, and put this, displace it here, and this one also comes at this side. So by using this both flaps, you're actually covering this exposed part of the root, suturing them. So because this flap is a partial thickness, it comes with a connective tissue from the adjacent side. If you think the thickness was not enough, it was a thin topography, then you can additively put a connective tissue graft here, and over that you put those double papilla graft. And then you suture them. What you obtain, this side which is partially denuded, the connective tissue would have been exposed. Epithelium cell would migrate from the adjacent side. It would again get reepithelialized. This one, it has connective tissue as its own flap also. And if that was not sufficient, you have put the connective tissue graft also underneath it, which comes with its own blood supply. So you will form gingival connective tissue attachment with the root surface. It would not be bony attachment. It would not be a true periodontium, but it is a coverage procedure. It's a cosmetic procedure. You are at least covering the exposed root, so it's providing you cosmetics, but it would not be as functional as your period because there still will be no bone here. It's only soft tissue coverage. That's why they are purely cosmetic procedures. Now, instead of double papilla, what you can do here, lateral pedicle can also be done. Lateral pedicle is same just as your double papilla. The only difference is that instead of getting the flaps from both sides, you are getting the flap only from one side. So lateral pedicle is, if you don't have two donor sides, use this one only and then move it and displace it and provide coverage. You can do it alone or give it with some epithelial connective tissue graft. But this is again going to be partial thickness. So some of the connective tissue would be left in this area. This would cover this exposed root surface. So your coverage is also provided, and this exposed connective tissue would be reepithelialized by your remaining adjacent epithelium. But meanwhile, for the healing, you will give a co-pack. You're not leaving it exposed to the oral environment. You give a co-pack so that the flap is healing here, new connective tissue fibers are forming here, and this one also gets reepithelialized. So if it's only coming from one side, it's lateral pedicle. If it's coming from both sides, it's double papilla. Other thing is coronally positioned graft. If you do not have, or if it was required to be done in multiple areas, your lateral pedicle or double papilla is usually done for a single tooth. Suppose you had to do it for your multiple teeth. So in multiple teeth, you would not be switching the papillas here and there, right? You would not be switching and providing coverage like that. Suppose it was this entire area you wanted to give coverage. What do we do then? Give an entire horizontal circular incision and give releasing incisions. So you have this all raised, and now this is going to be your full thickness. It is going to be a full thickness flap because you're going to coronally position it. You can't displace it unless you extend the vertical incisions into your alveolar mucosa, because only alveolar mucosa is stretchy. If your incisions are only in attached gingiva, would you be able to stretch it coronally? No. To want it to stretch it coronally, you have to extend the vertical incisions into the alveolar mucosa and then coronally position it. Then if it was your generalized recession, then you coronally position the graft and provide the root coverage. Underneath that coronally positioned graft, you can place your connective tissue grafts if it lacks the blood supply, or if you think that there's large area of healing which requires some more additional blood supply, so you can use it with your added connective tissue graft. The added connective tissue graft is coming from certain other donor site. That would be your hard palate. So in your hard palate, you would be extracting the subepithelial connective tissue graft and putting it here at the recipient bed, over which you will position your coronally positioned graft at a higher level, which is providing the root coverage. So I hope some of it is making sense. It's not important that you understand all the grafts today. When I start perio, I'll explain them again. I'll give you articles also to read. But I hope some of it is starting to make sense that yes, there are procedures to give you root coverages, there are corrective procedures. Now this patient, for all these methods that you're doing with subepithelial connective tissue grafts, lateral pedicle, double papilla, coronary repositioning, they're all cosmetic procedures. You must carefully select the cases. The presence of adjacent interdental papilla is an important here. If your interdental papilla is also receding, then the coverage that you will obtain is impossible. And in lateral pedicle and double papilla, if the interdental papilla is also receded, then there's no donor site. You can't do that. So total root coverage is very difficult to achieve and unpredictable, especially in the long term. So please select the cases carefully. But coming to the functional aspect for the patient's problem, which is that her recession should be stopped because she lacks sufficient amount of functional attached gingiva here. So in this case, what was done for her is, because there was no attached gingiva, hardly attached gingiva here, hardly any attached gingiva in these incisor sites. So this is the graft that was placed, if you can look at it. Do you see this pink looking tissue here placed on the alveolar mucosa? Now, because there was all non-keratinized mucosa, which is the alveolar mucosa, they wanted to give some attached keratinized mucosa in this area. So they brought a free gingival graft, which comes with the donor site definitely is be from your hard palate because you require keratinized mucosa. Hard palate is keratinized. So you need a functional zone of attached gingiva for which you'll get a palatal mucosa graft and you'll put it over the alveolar mucosa and then it would attach to the underlying root surface. You will not just simply tape it to the alveolar mucosa. You'll denude this area. You'll denude this area partially. It would have certain blood supply and then you'll suture this one. Now, free marginal graft or free gingival graft usually comes with very less blood supply. So it cannot be given on the denuded root surface. It only has to be given where the bone remains. Because if the bone remains, then you have your vascularity. Root doesn't have its blood supply, not externally at least. Root surface doesn't have blood supply. Bone on the root surface had blood supply. So you can only place your free gingival graft on the areas where there is bone. But what you're achieving is you're not achieving coverage. But instead of having non-keratinized alveolar mucosa here, which was more prone to destruction, now you have given keratinized tissue piece here, which is attached to the bone, which will resist the pulling forces of the lips, which will prevent the further recession. So you're making it a functional attached gingiva zone. So this is more like a therapeutic procedure which prevents and arrests the disease, right? Which makes it more resistant to recession, less prone to soreness. And a free gingival graft is the treatment of choice for this patient. And thus, even if the gingival margin has little attached gingiva, it can remain healthy and protected if from the displacement or other trauma, if it doesn't get pulled back. Now, other method is giving a thin acrylic gingival stent or veneer, which you can get in acrylic, pink color acrylic, but that is completely prosthetic procedure. Certain areas in aesthetics areas where your coronally position grafting or coverage procedures or coverage surgeries are not advisable or not doable, in those cases, you can provide excellent cosmetic results by using a prosthesis in your acrylic, but they are rarely used. So these are the possible treatments. I hope you got the sense of the treatments. Now what you see, and in this case, this patient, a free gingival graft was placed. And the result is shown in the picture, which I just showed you. For 3 teeth, you have put your free gingival graft. So the graft appears successful. Palatal connective tissue and overlying epithelium was taken from the donor side, placed apical to the gingival margin to provide a wider zone of attached keratinized gingiva. Because the palatal connective tissue is transferred, the epithelium retains its keratinized palate structure. And does the graft need to lie at the margin? So the graft material that you're bringing, would you make the margin out of it or you place it below margin? So you don't really need to put it at the margin. Marginal gingiva which remains is, in certain situations in this place, is your keratinized. Wherever the marginal gingiva appears pink, that's your keratinized gingiva. But for this incisor, the marginal gingiva was also an alveolar mucosa. The alveolar mucosa only was acting as your marginal gingiva. There was barely any attached gingiva. So only in this case here, it has been placed to replace the margin. But in other situations where you have this keratinized marginal gingiva, in those 2 situations, you have placed it below the margins. So it is not required always that you put it over the margin. You can keep it below the margin as well. Then why not place the graft over the root as well and correct the recession? So as explained, that surgery to correct the recession itself is difficult to achieve and unpredictable, especially in your long-term procedures. And the root surface does not provide any nutrient bed or blood supply on which the free graft can survive. If you want to give balance, you have to bring a connective tissue graft, a subepithelial connective tissue graft, which is thicker, which comes with its own blood supply and can stay there and maintain its vitality. Free graft is most unlikely to be successful if simply placed over the root surface. So your free graft would be placed on the bone, whereas your subepithelial connective tissue graft for coverage can be put on the root surface. So there would be questions on these concepts. So I hope these are starting to make sense. When we start doing the questions also, we link up those questions with this concept that you're learning today. So now figure shows a different patient with recession. What does the appearance tell you? Now this is another patient again dealing with localized recession here. It's approximately 4 millimeters of recession buccally on the canine, apical to the gingival margin. There is also a hole in the gingival tissue. Plaque and subgingival calculus formed within the periodontal pocket are visible and tissue is inflamed. There is a small bridge of tissue above this fenestration, which is not attached to the tooth surface and will eventually also break down. In this case, the recession is secondary to the pocket formation in plaque-induced periodontitis. So here the cause is there is plaque and calculus. When you see the etiologic agents, then it's plaque and calculus. Whenever the plaque and calculus leads to recession, then it's always categorized as periodontitis because this is also loss of attachment. So periodontitis is solely the loss of attachment where the etiologic agent is plaque and calculus. Here you can see in this previous patient there was no plaque and calculus. That's why it was an unknown etiology. It was an unknown etiology because there was no plaque and calculus. If this patient also had a lot of debris, plaque and calculus, then yes, it would also have been because of your periodontitis. So this patient is periodontitis. This was in periodontitis. Inflammation associated with calculus has caused loss of the buccal bone, which looks like a fenestration here, ultimately with destruction of the marginal bone and the marginal gingiva. This also would become the part of deeper recession. How would the treatment of this patient would be different? Well, only the early stages would be different because you would have to remove the etiologic agents. You first treat the inflammation, remove the etiologic agents, perform subgingival debridement. Once the tissue is allowed to heal, there is resolution of inflammation, the treatment has been, the situation has been reversed, there is no more periodontitis. Then only you're left with is the root exposure. Recession would be there, bone loss is still there, that's irreversible. You're left with that gingival recession site. Periodontitis is managed. Then what do? Same management. Whether the patient requires coverage or they require only the arrest of further progression. If the arrest of further progression is only what you desire, then you give functional attached gingiva. And how do you give functional attached gingiva? With your free gingival graft. If they desired coverage and it's a single tooth site, how do you give coverage? You have various options available: double papilla, lateral pedicle, or your coronally position graft. If your donor sites are healthy, if the interdental papilla is healthy, you go with your double papilla or lateral pedicle. If there's no interdental papilla, then you may have to perform your coronally position flap. But the prognosis of the same would be poor because interdental papilla, when lost, even the coronally position flaps have only or provide only 20% coverage, not more than that. So that's extremely poor prognosis. But this is a single tooth situation. So either you give a free gingival graft to prevent further recession because that's also now almost an alveolar mucosa, or otherwise you go with your lateral pedicle or double papilla graft. So that was the discussion of case number 4, recession and its management. I hope some of it made sense. Gradually more of the perio would start making sense. So obviously when we build more information, more knowledge and more discussion when we start the perio, when you come to the perio B, more information will be added and more things would start making sense. So please understand this is a journey. We'll be building on the concepts. Nothing would be built up in a day. And not all the concepts can be learned in a day. But that's where you have to somewhere start. Anurit, yeah. So this case, gingival topography is the reason, yes, because no other etiology was found, and they have emphasized that all of the factors are contributory, so gingival topography is the most likely cause. But they have not completely disclosed, they could not come to the correct etiology. All right, rest of the doubts, please direct to my personal WhatsApp chat because there are very personal doubts like difference between the graphs and all. They require a lot of pictures and imagery, which I've tried to explain. And as I said, it cannot be all explained in a single class. We have to gradually build on all this information. If we started answering all these questions, which are a bit elaborate, where to use those graphs, where to use each graph, that would take up an entire 2 hours. So let's just rejoice what we have learned today. Let's just gather what we have learned today. And yes, we'll build more on that. Yeah. So there's still a lot to learn on graph. As I said, that is the first lesson in perio. This is the first day of perio. So you know that where we are heading in perio, right? So there's going to be a lot of learning. Perio is going to be extremely interesting. So ironically, perio is where most people struggle, and still perio is the one which you can very easily master and grasp. It's very friendly subject. I would say it's readily understandable, only if you pay attention to it, right? So let's keep on building. Let's keep that spirits high, and we will learn greater depths in perio. So for now, that would be enough for today's class in perio. And let's take a due break. I'll take only a 10-minute break today because it was obviously we have to cover up from the last class also. So we'll only take a 10-minute break, go grab some drinks, freshen yourself up. I'll see you in 10 minutes, and then we start the trismus chapter, which again is an important concept regarding your TM joints, your discs, your trismus, your MPDS. Again, it's a vast concept, it's a vast topic. So I would not be able to cover everything regarding that in a single day, in 1 hour. So please also take that class as the first core builder class. And there would be a trauma article, the TMJ article I would be sharing. So now you can put to the list. The TMJ article has to be shared after that. And gradually we will build more on your TMJs as well. So you learn a lot through the course. Every concept would be strengthened. The end results, but yes, definitely would only be evident once we have completed at least 3 to 4 months of this course. So please maintain your patience levels. Please keep studying. Please keep reading. Keep understanding. Bearing with me of this process. Trust in the process. By the end of 3 or 4 months, you will be dramatically surprised the level of information, the level of knowledge that you have gathered. Okay. So let's take a quick 10 minutes, and I'll see you in 10 minutes, and then we start your trismus case. That is your case number 8. But very good, very interesting concepts you learned today in that chapter. Okay. So I'll see you guys. I'll see you guys in 10 minutes from now. So the roster contains only about 38 to 39 cases that we'll be discussing in classes, but not to emphasize less on it, the entire book has to be done. All right, so let's begin with painful trismus. Amazing, interesting concept about TM joint and its problems, what all it can be and how they may clinically represent. And in fact, how with your clinical representation of a patient situation, you can in fact even clinically diagnose that what would be the possible etiology. So it's about a 27-year-old woman who is unable to open their mouth normally. What is diagnosis and how should she be managed? So let's look at this clinical picture here. This is the right side of the patient and this is the left. So if you notice that because the mandible being the movable jaw, so this is the midline on mandible and that's the midline on maxilla. So the deviation is towards the right side. This is the only opening of the mandible, the mouth, and also upon opening there is deviation towards the right side. So these 2 clinically important points that you have noticed from this picture, that is less opening than normal, and also the deviation is towards the right side. What does both of these clinical features mean? We'll learn just in a while. So this is the patient on presentation, which is a maximal opening for this patient. This is not a normal opening for any normal person. This is a maximal opening for this patient. The patient is unable to open their mouth more than half the normal distance. She has had sporadic painless clicks from her right jaw joint for many years. Recently, the click has become louder and painful. On occasions, there has been some hesitancy of opening just at the position where the click would normally be felt. 3 days ago, while eating a particularly chewy piece of meat, she felt a sudden pain in front of the right ear. And since that time, she has been unable to open her mouth more than about halfway. So if ideal opening is say about 44 millimeters, she's somewhere opening closer or slightly more than 22 millimeters. So the sequence of history is that it started with a painless click on the right side, right joint, which graduated to become slightly disturbance and opening. And then there was some development of pain and then limited opening. So now there is limited opening, no opening beyond a certain point. So it started with a click and now she cannot open beyond a certain point. That means her jaw is locked. So it started with a click, progressed to a lock, and this lock, because she cannot open. So when you cannot open something, that's a closed lock. And when you cannot close something and it remains in an open position, that's an open lock. Remember these two terms? Closed lock means, if you get confused, because I used to get confused a lot. So closed lock means that the lock or the jaw is in closed position. There would be normal closed position. When it's open lock, opening position would be the normal position and closing would be difficult. In closed lock, opening is difficult, closing is normal. In open lock, opening is normal, closing is difficult. Right? So because this patient can close correctly, cannot open beyond a certain point, so it's a closed lock. It's lock in closed position. So started with click, painful, and then lock. This is the progression. Medical history, patient is otherwise well, but she has suffered from previous episodes of knee pain, was seen by a rheumatologist and diagnosed with generalized hypermobility of the joints. She used to be a successful gymnast also as a teenager. She is apyrexial, no fever, no facial swelling, skin color is also in the preauricular regions normal, no signs of inflammation, that means. All right. So we are gathering information as we go. There is tenderness on palpation over the right condyle, but no tenderness on the left side. Deviation on the right side. Click started right side. Tenderness on palpation on the right side. So we are dealing with the right joint problem. The deviation concept, I'll explain why there is deviation on the affected side. That much you have gathered here, that because the click started the right side, tenderness is on the right side. That means the affected side is which one? Right side. And the deviation is also on the right side. So what conditions and why upon opening the deviation is to the affected side? I'll explain in a bit. For now, there is generalized muscular tenderness, particularly of the right masseter, right lateral pterygoid. So same side affected side, muscles of mastication also involved. Examination of the fingers, wrists, elbows shows an increased range of joint movement, which is also in agreement with the fact that she has hypermobility of her joints. The patient's appearance is shown. She's trying to open her mouth to the maximum extent. What do you see? There's limited mouth opening, deviation towards the right side. If you're able to examine, you will find that the opening is about 23 millimeters. That's slightly more than half of the normal opening. Lateral excursions of the mandible was measured 8 mm to the right. So if they try to laterally deviate their jaws, lateral excursion to the right was 8 and to the left was again 1. That means on the unaffected side, the lateral movement could not be done, but it could be excurted laterally towards the right side. All this relevance, we'll connect the dots together. Just stick to the information, you'll know how to connect the dots. Patient readily achieved a normal position of closing, that's maximum intercuspation between upper and lower teeth. So closing is normal, opening is abnormal, it's a closed lock. Patient has trismus. What is trismus? The definition is that reduced opening caused by spasm of the muscles of mastication. But the term is also loosely used for other causes of limited opening. True trismus is usually temporary. True trismus actually only involves muscles, but now it is generally used whenever you have opening problems, it would be classified as a trismus. The cause could be many other than muscular as well. So what are the various causes of trismus? There could be intra-articular, that means within the joint. Extra-articular, externally then your TM joint. Within the joint, it could be the internal derangement of the joint, of the disc. Derangement means the abnormal position of the disc, how it should be placed. So internally, the disc has been deranged, abnormally positioned without reduction. That means it is not even coming back to its original normal form. Internal derangement of the disc has two forms, with reduction, without reduction. If it's happening with reduction, that means the disc is coming back. Reduction means going back to its position. So if it's going back to its position, that means internal derangement with reduction. That will give you only a click. But if it's internal derangement without reduction, that means it's not coming back to its normal, it is stuck out of the joint. That is, it's without reduction, and then the joint would be unable to move completely. The condyles will be stuck, and that will give you either your some closed lock or your open lock. And we'll talk about the locks also. So internal derangement without reduction also gives you difficulty in opening the mouth. Fractured condyle, when the condyle gets fractured, the condyle head also moves ahead, and that will be unable to complete its rotational and translatory motion throughout the condylar eminence and would be unable to open on that side. See, opening of the mandible is condyle moving translatory motion throughout your articular eminence. So it goes out and forward in your articular eminence. If the condyle is unable to do that motion, that means it is your open lock, or it would be a trismus, inability to open the mouth. So condyle cannot do the translatory movement in forward direction. That means the patient is unable to open their mouth, at least from that particular joint. The other joint may be normal, and that part of the condyle may be completing its range of motion, but not be affected. Then traumatic synovitis, which is also the inflammation of within the joint because of trauma, septic arthritis, osteoarthrosis, inflammatory arthritis, ankylosis, lesions on the condylar head. All these affect the joint. So that's why it would be intra-articular causes because of the inability of the joint to complete its range of motion and lead to opening of the mouth. Extra-articular cases are trauma, which led to fractured mandible, but condyle was not involved. That means externally it led to fracture of the body of the mandible, which somehow hampered the muscles of opening of the mouth. Because as well as your joint is involved in opening, the muscles are also involved in opening. So if the muscles get affected through trauma, through post-surgical removal of third molar because of the inflammatory fluids in the spaces, muscle of masticatory spaces, acute infections involving the masticatory spaces. So whenever muscle gets involved due to your post-surgical trauma, your actual trauma or fractures, or your acute infections, those are your extra-articular causes where the muscle is responsible. It could be the direct muscle spasm, disease of the muscle, scarring of muscle, inflammatory condition of the mucosa, tetanus. Where the muscle gets involved, that's extra-articular cause. Where the joint gets, or condylar head or disc gets involved, that's your intra-articular. Broadly, you know the two causes of trismus. Now, what are the common causes of pain in the joint? Because she also has inability in opening, and she also has pain on palpation on the right side of the joint. So we will be further able to shortlist our list if we knew amongst these conditions what gives you pain in the joint as well as inability to open. So you can actually shortlist them. So amongst these, there would be three conditions which would give you painful joints: MPDS, internal derangement of the disc, and osteoarthrosis. All these three also are involved with your inability of opening the mouth, and these three only would be involved with pain in the joint. So MPDS, myofascial pain dysfunction syndrome, also known as arthromyalgia, or sometimes TMJ pain dysfunction. So this definition is no more used. This is incorrect. You can't call an MPDS a TM joint dysfunction. It is called TMD or MPDS. When you say TM joint dysfunction, that has to include condyle or the disc. TMD, temporomandibular dysfunction, or MPDS does not involve the joint. TMJ dysfunction only includes joint or condyle. So MPDS is called either MPDS or temporomandibular disorder, but would not be called temporomandibular joint disorder. So in this condition, the masticatory muscles which move the joint, they are the source of the pain. Condition has nothing to do with the joint itself, initially at least. Yes, with your MPDS progressing later, then the joint may get involved as a side effect, but not would be the part of this condition. The pain is described as a diffused ache over the side of the face where the muscle of mastication, especially the masseter, is. If you have a tight, heavy or a dragging quality, it would be like a chronic, dull pain rather than an acute pain. Pain can be mild or severe, usually would fluctuate in intensity with bouts of exacerbation, which would last hours or sometimes days. Two presentations are seen, one which is worse in the morning and one which builds up through the day and gets worse in the evening. Well, that depends upon when the bruxism takes place. Because MPDS is linked with hyperactive muscles. So if the patient has nocturnal bruxism, bruxing through the night, muscles are tired up through the night, the pain would be worse in the early morning. If he's a morning bruxer, during the daytime bruxer, it would build up as the day progressed and would be worse in the evening. Common sense. Movements of the jaws are sometimes painful, but not always. Mouth opening is sometimes restricted. Tight bands within the muscles are thought to be the cause. And the condition also affects other parts of musculoskeletal system where it may be termed fibromyalgia. If not just muscle mastication are involved and entire skeletal system muscles are involved, the voluntary muscles, then it would be termed as fibromyalgia. If it involves generalized skeletal muscles, then fibromyalgia. If only masticatory muscles, then MPDS. That's one cause. Interderangement now. So internal derangement of the disc is used to describe instability or the abnormal position of the disc, usually where it is anteriorly displaced, which gives rise to clicking and locking of TMJ. And we'll come to that because this patient is particularly suffering from this condition. Osteoarthrosis or degenerative joint disease, age-related, seen in TM joint, condyle in particular, linked with wear and tear of the joint, causes probably a failure of cartilage repair with a genetic predisposition, fibrillation, cracking and fraying of the disc, loss of proteoglycans can lead to the breakup of articular surface. It will be painful on movement, especially when the joint is loaded, for instance, during chewing. There is restriction of movement in all directions. There will be crepitus, grating sound while opening and closing the jaw. Why do temporomandibular joints click? Now, this patient's problem began with click. If you remember, we drew that click, then the hesitant or the reluctant movement, and then complete obstruction of the complete opening movement. That's how it progressed. So why was it clicking at the first place? So basically, the stretchability or the laxity of the posterior distal ligament, which attaches the disc to the posterior part of the articular eminence, sometimes because of that stretchiness, the disc moves forward into an abnormal position. That's your disc lying over the head of the condyle. It has a distal attachment. So because of this laxity, it stretches out and it comes to lie anteriorly on the condyle. The disc can be trapped and stretched forwards, but further movement, when you try to open the mouth and condyle also starts moving forward, it pulls back. The distal ligament pulls it back with a snap into the normal position, giving you a click, and that's called opening link because the condyle was coming forward, disc snapped back. That was a opening movement of the condyle, so it's an opening click. Closing click is now the disc is backward, condyle is forward, condyle wants to go back, condyle is going back, and then condyle is repositioned posteriorly, and the disc again, like in original position, comes back with a snap. Again, giving you another click on coming anteriorly. So that's called closing click because now the condyle was going back and the disc came forward, giving you a closing click. If the patient has both opening and closing leg click, then he's suffering from reciprocal clicks. The articular disc has been moving to and fro in both opening and closing movements. So let's look at the diagram also, very simple to understand here, now that you have also read this. This is a normal patient. Condyle first does the rotational movement. When you try to open, first is pure rotational axis, which gives you that 23 millimeters of opening in this patient. That's your pure rotational, which would not be hindered because of abnormal disc position, because disc position affects the translatory motion, not the pure rotational motion. So initial 23 mm condyle will open during the rotational movement, then the condyle tends to move forward translatory and the disc goes back with a snap. Here, this is the abnormal. So disc was anteriorly positioned, condyle started to move forward, disc goes back with a snap, giving you the opening click. Then condyle goes back to the normal position posteriorly, disc comes forward again with a snap, giving you the closing click. In ideal situation, disc should be at the head of the condyle at all the times and should glide with the condyle head, not snap ahead or posteriorly to it. Here, it moves, it is to start with, is located anteriorly. When the condyle starts moving forward, it pulls back with a snap, giving you an opening click. When the condyle starts to start the closing movement, goes back, the disc again pulls forward with a snap, giving you a closing click. So patient who has both these clicks is called your reciprocal clicks. Now, what would be the lock or the closed lock where the patient is go beyond a certain opening? That means beyond a certain 23 mm pure rotational opening. Beyond this, he cannot move. That is a lock. That means the disc was stuck outside the condyle. So pure rotational movement the condyle was able to do, open up to only 23 mm. And then the disc was so hard stuck ahead of the condyle that instead of pulling back with a snap, it is not going back and it is not allowing the condyle to also move ahead. So disc is stuck at the ahead position. Disc is not pulled back like it was getting pulled back in the clicks. So initially the patient's disc was more pliable and moving back and forth with clicks. Now it has gotten so stuck that the condyle is getting obstructed behind the disc and only able to do the rotational movement, not able to completely open with the translatory motion. Hope that made sense. Clarified? I assume so. Please write down yeses if you're getting it. So that's how you understand the clicks and your lock. Why do joints lock in internal derangement? Well, we just read about it. Sudden locking of the jaw or inability to open implies total obstruction of forward condylar movement. That is translation is lock. There are two types of lock, closed and open lock. Locking and clicking are presentations of the same process. Internal derangement. Derangement is abnormal. Till the time it was getting reduced back with reduction, only click. Without reduction, open lock. If the discal ligaments become very stretched or even ruptured, then the disc is permanently positioned forward in ahead of the condyle and completely obstructing its forward translation. Locking of this type is acute in onset and usually follows many years of click when the disc completely gives up or the distal ligament completely gives up and the disc is stuck ahead. In this case, condyle is stuck behind the disc. Patient cannot open their mouth. Condition is known as closed lock. In the open lock, what would have happened? It is called subluxation or dislocation of the joint. Why? Because open lock means it is not closing. Patient would have come to you with an open jaw. He would not be able to close it at all. That happens when the condyle completely comes out of this articular eminence and comes ahead of this disc, and then the disc is behind the condyle, it cannot move back. It has been dislocated. It's a dislocated joint. The condyle which remains in the eminence, it has come out of it. So it cannot go back because the eminence is also obstructing it, the disc is also there. That has to be manually repositioned. That is a subluxation or a dislocated joint. That's your closed lock. That's simple. Open lock is the mouth where it's locked open and only condyle is doing rotational movement, 23 mm opening, and that's your closed lock, where the patient can close, cannot open beyond certain extent. Now, does this patient have an intra-articular cause or an extra-articular cause for the locking? So the crispness of extra-articular origin and its capacity to move are unaffected. Like, if the cause was extra-articular, that means only muscles were the reason that the jaw is not opening completely, then the movements would be restricted only in the vertical direction because the muscles are arranged like this. The opening and closing would be a problem. But your rotational movements, lateral and protrusive movements are caused by joints. And because joint would be normal, so the lateral movement and protrusive movements would have been normal. In your muscular cause, lateral and protrusive movements would have been normal. But this patient shows an abnormal lateral excursion on the left side, only 1 mm able to move on the left side. So is the right condyle, which is the working condyle when you're trying to move the jaw laterally to the left side, is it moving? No. Because the right side is affected side. Lateral movement towards the left would be affected because right side would be the one trying to move the jaw to the left side. That's the working condyle. So if working condyle is ailing, that's your right condyle. So the left lateral excursion is incomplete. And that's why in this patient, it's not the extra-articular cause, right? Because condyles permit normal protrusive and lateral excursion when the muscles are involved. In this case, because the joint is involved, that's why the lateral excursion is also affected along with vertical opening movement. So when the cause is intra-articular, forward translation of the condyle is normally the first movement to be lost. Then the component of joint movement occurs in the upper joint space required for opening and lateral excursion. So with joint problems, all direction movement of mandible is affected, like in the present case. What is the most likely cause here? So we know that's an intra-articular cause, and there is no history of surgery or trauma, no fracture, no inflammation visible, no arthritis cause. Traumatic synovitis is also a possibility, but that does not usually cause selective involvement of one joint and not the other. All joint movements are painful. This leaves internal derangement of the disc without reduction as the most likely cause. Progression of the click to the locking with the pain and intra-articular trismus of rapid onset is typical of closed lock and fits the pattern of symptoms as seen in this patient. In this case, the patient is still able to translate their left condyle forward, causing the deviation to the right on opening. Now, why does the jaw deviate to the affected side? This is the right condyle, that's your left condyle, and that's your mandible connected with it. So here the disc was stuck ahead of the condyle on the right side. Left has normal disc and condyle relation. So if this jaw is stuck, this condyle is stuck, it is only doing rotational, not doing translation. This one is doing rotational and also is slightly able to come forward translatory because this is not stuck behind a disc. So if left condyle is completing its range of motion, so instead of coming forward and getting it open completely, because it requires both the condyles to give components in vertical direction to open completely, so right is stuck, left is completing its range of motion, but that gets deviated towards the affected side. So instead of opening, it rather deviates to the affected side because somewhere that motion has to go. That is some motion. Some kinetic energy has to be transmitted and you have to obtain the outcome. So instead of getting opened, which would require this component also, so that's not happening here. Instead, this condyle completes it and deviates the mandible on the affected side. So right side unable to move, left side completely moving, but instead of going down, it then takes a translatory lateral course. So laterally deviated. And when you're trying to laterally deviate, do side to side movements, right is the working condyle when you're moving the left, when you're moving the jaw to the right side. So when the left is working, the lateral excursion to the right is 8 mm complete. When the right is the working condyle, the lateral excursion would be made to the left side. And because this is dysfunctional, the left side lateral excursion is only 1 mm. That also is clarified and justified. Therefore, the cause of restricted opening is internal derangement without reduction of the right joint. What investigations can help? Well, plain radiographs would not show you any abnormality because these are all changes in the disc and not hard tissue changes. But usually an OPG would be the first view of choice. Then you will have to take a CT scan, which will show you the disc and the joint relationship. MRI also show you malposition disc. Then you can perform arthrography by injecting a contrast medium and then taking your normal X-ray. And serology, if you were suspecting a rheumatoid factor or rheumatic arthritis, although that is not suspected here, but if it was suspected, then sometimes you may find antibodies against or your rheumatoid factor autoantibodies in the serum, but they may also be missing in certain patients. But here the clinical picture is sufficiently clear to make a diagnosis that it's your intra-articular disc-related derangement cause, so you do not require serology. And now if you wanted this condition to be managed, so internal derangement without reduction with a closed lock, in most cases, resolves spontaneously. A consensus view supports conservative management for a period of at least 3 to 6 months with prescription of analgesics. It should be gently mobilized. Forced manipulation in the early phases are not helpful. Used to be thought that dislocated disc should be surgically repositioned by doing an open joint surgery. This procedure produces about a 90% cure, but the same result is obtained even when you're spontaneously handling it. Proponents of the joint surgery argue that the disc needs to be pulled back into its normal place, and then posterior distal ligament attachments also need to be shortened so it's kept in place. However, the MRI studies after the surgery show that the relapses are happening, and that the anterior position of the disc is also sometimes perfectly compatible with your normal joint function. Your joint can adapt and remodel around this abnormal anterior position of the disc, so you don't have to surgically intervene. So that's definitely wait for 6 months. And if it persists longer than 6 months, then you may also do arthrocentesis. That's injection of saline or Hartmann solution into the joint, which breaks down the adhesions between the disc and bony joint. Because disc is now stuck ahead of the condyle. In 6 months, the disc would have formed some certain bony adhesions with the joint and with the articular eminence. So this arthrocentesis can break those bony adhesions, and then you can get some response and the disc gets free, and then you can get some repositioning with conservative management. So either you can perform the blind procedure, or you can use an arthroscope and then perform the lysis and the lavage. That's your surgical management. You briefly know it. That's very good enough for the exam. In the event that this procedure is also not successful, then yes, you surgically open, disc replacement, disc meniscectomy, they can be indicated, but they will be only required in a very small number of patients. Is there anything significant in history of joint hypermobility? Well, yes, hypermobile joints are at higher risk of TM joint derangement because their ligaments are also hypermobile. As well as damage to other joints will also be more possible and they would be vulnerable. However, only a small portion of patients with TM joint derangement will have this particular hypermobility. So not all cases of TM joint derangement are hypermobile. Some of them may be hypermobile. Joint hypermobility would not be the result of her being involved in gymnastics, but yes, because of her hypermobile joints, that could be a likely reason that she performed well in gymnastics. Now look at this MRI, and this MRI is also given in the exam so many times. This MRI is absolutely given in the exam. That's how we've all read and understood today. That's your condyle, and that's your disc ahead of it. And that's your normal condyle and normal relationship of disc, where the part of it at least is covering the condyle. Here it's E, it's your external auditory meatus. Here the disc is stuck ahead of the condyle, so condyle cannot move forward. And this is this patient's MRI with the closed lock. Condyle stuck behind the articular disc, and patient unable to open the mouth completely beyond the rotational axis. So that would be the completion of today's class. I can go on and take 5 more minutes of doubts if you have any here. So I hope you enjoyed this class and the concepts made sense. The discs and the clicks and the locks also made sense. All right, so that would be for today's class. We are meeting on Wednesday now. We'll be doing the next from the roster. Please check your roster for week 2, class 2. We will finish this off and also do maybe 1 or 2 more sheets from the past class that is remaining, which are your endodontic file, MCQ endodontic file. So maybe we'll do the page number 18 and 19. If the time allows, we can also do more. Let's see. So we'll try to also finish our backlog from the last class and then also do the decided curriculum for that class. That would be 1 Odell case and few pages from your 1000 MCQ file. All right, so I will be uploading the references. Tina, please send me those references list, and I will be uploading this Odell file with notes along with 1000 MCQ file with notes, and also the recording for today's class, which you would only be able to access with your credentials signed in. If you're finding difficulty in re-watching those recordings, please make sure you have to sign in each time with the credentials that you have used to register with us. Okay, get a hang of it. Yes, Nadia, most likely. I will announce if it is otherwise, but I'm most likely after this class going to look at the new Odell, look at the case number that we were supposed to do, and if I find it more interesting, more pictures, more to read, then yes, definitely we are hopping on to the new one. Yeah, Akash, what is your question? Akash, could you please type that question again if you don't mind? Yeah, okay, I'm waiting for it. Okay, Pritinder, I'll take your doubt for till that time. Why not coronal flap with free gingival graft in last case? Okay, first of all, coronally positioned flap is not accompanied with your free gingival graft. Free gingival is mostly your epithelium with your some connective tissue for smaller areas, right? Where you're getting the keratinized tissue. Coronally positioned flap aim is to provide coverage. Why would you do coronal flap with free gingival graft? If you do coronal flap, you have to get only the connective tissue part because you're pulling the epithelium with the flap. You don't want free gingival graft for that. You only want the connective tissue underneath for its connective tissue bed to give you some blood supply underneath. So coronal flap is a coverage procedure. Free gingival graft is your functional attached gingiva thickness increasing procedure. Those are very separate outcomes of these two flaps. So you are not mixing them. Coronal flap comes with connective tissue graft. Free gingival graft does not provide coverage and comes from only smaller surface area and has to be only put where the bone is, cannot be put on the roots. I hope you got that. We'll get more clarity with it, but I hope some of it got clear. Difference between free graft and subepithelial graft is exactly the same, Akash. One comes with epithelium, one doesn't come with epithelium. One can only come in certain amount and only requires free graft has less amount of connective tissue thickness as much as your subepithelial would have. Subepithelial has more connective tissue thickness because you need more vascularity to be you're putting that on the root surface, not on the vascular bone bed. Okay, so Akash, I think yours is also sorted along with Preet's. I was actually also explaining both separately. Yeah, perfect. Let me take it down above. Whose was that? Parvati, I'm coming to yours. In the painful joint case, she has generalized hypermobility. Does it suggest systemic involvement? It is a generalized hypermobility. It is not per se a systemic condition or a systemic disease. But yes, generalized hypermobility means all the joints in the body are involved. Yes. If by systemic you means all the joints in the body, yes. By generalized that means systemic. But no other organ or no other part of the body, it is not a systemic disease. Free graft is also taken from the palate because you require keratinized mucosa. Whereas in the mouth you'll find that much keratinized mucosa and a good donor site. Yeah. In last case, there was no attached gingiva, so they did free gingival graft to increase attached gingiva. Yes, absolutely correct. That was a question or a statement. So they did not do a coronally positioned graft, Preet. Please, if you have more doubts regarding to that. So root coverage was not desired in this patient. It was not intended because it is not as successful and the patient did not want cosmetic correction. That's why. So not all recessions require cosmetic corrections. That's what the intent of this chapter is. That even if you arrest it, patients can be happy. Yeah, I think now that's put across. All right, so that would be it. More doubts, please send it to me personally. I would be happy to take them. You'll get the answers by tomorrow. Yes, Akash, I agree with you. Function is more important than aesthetics. And yes, that would be the end of it. See you guys tomorrow. See you guys on Wednesday. Thank you for taking our time and joining with me. See you guys on Wednesday.